And I see some of our frequent flyers and some new names, people I know, people I don't know yet personally. Really appreciate your engagement. So good morning, good afternoon, good evening, wherever you are. Welcome to ISGyP Live Journal Club. The theme today is going to be artificial intelligence and informatics. And we've taken a little bit of a non-traditional approach to choosing the papers. We did not want all three of the papers to be sort of pure AI. We're focusing on moving information around and using data to support claims about patient tissue and disease. So my name's Ian Hagemann. I'm speaking to you from WashU in St. Louis. I'm the co-moderator along with Dr. Becca Wolsky from the University of Colorado. And please feel free to say hello in the chat and let us know where you are in the world. Once again, we really appreciate that you've come to Journal Club. Live is our interactive educational program sponsored by the International Society of Gynecological Pathologists. I'm highlighting here some events that have happened recently. There was a excuse me, panel discussion, webinar, and a slide seminar that if you are a member of ISGyP, you can view the archived recordings. And then we have a couple of upcoming events, podcasts that'll drop on June 26th, and interesting case presentations given by trainees and new in practice pathologists. And so that's coming up on the 26th also. You can register at isgyp.ca. You can also preview the slides from the interesting cases. And since these links are not clickable for you, we'll drop the chat during the session. So please visit isgyp.ca. This journal club is global. We have two concurrent cycles. One focuses on the Western Hemisphere time zone, so it's at noon U.S. Eastern Time on the third Wednesday of the month. That's what you're attending right now. We also have every alternate month is in a time zone that's more focused on the Eastern Hemisphere, noon Australian time, the Eastern Australia on the third Thursday of the month. So it may be easier to attend one or the other of those. We have a schedule of topics. We're in June. We're doing a special theme of AI and informatics. Next month, the Eastern Hemisphere will cover ovarian epithelial tumors and fallopian tube and so on. We take a break every year for USGAP in March and for the December holidays and end of the year in December. So we would love to have volunteers, and so you can volunteer for any of the three formats that have trainees and new in practice pathologists as presenters. Just send an email to any of the people that you see listed here, and we all talk to each other all the time and are willing to pass names around if we don't have room for you on the schedule, but someone else does. So the Western Hemisphere Journal Club, the Eastern Hemisphere Journal Club, or the interesting case presentations are all constantly looking for presenters, although the schedule is kind of full up for 2024, but there are slots out into the future. And just a little additional note, several of these formats are also looking for volunteers to be moderators. So if you're more of a senior pathologist and interested in one of those opportunities, just email any of the people you see listed here. All right, now to the main event. We have three great presenters today. We have Dr. Francesca Vacca, who is a third-year resident at Barnes-Jewish Hospital in WashU in St. Louis. That's my institution also. And she'll be presenting this paper by Levin et al. Dr. Frankie Cheng is a second-year AP resident in Hong Kong. So actually, it is midnight for him. We appreciate him tuning in to present. He's presenting a paper on BRCA reversion mutations. And then Dr. Sylvia Jang is a graduating resident at Houston Methodist, and I'm excited to say she'll be joining us in St. Louis. She'll be our Gyn and Breast Fellow next month. She's presenting a paper on computer-aided prediction for Pipelle biopsies, image analysis. So just a couple of brief words about the format of Journal Club before we turn it over to the presenters. The objectives are to engage pathologists in learning about the current literature and how to evaluate it critically, and to offer opportunities to elevate trainees and new in practice pathologists from all over the world through mentorship, speaking opportunities, and camaraderie. The format that we use for the journal club focuses on the sections of the papers, first understanding the background, the methods, the results, the conclusions that the authors draw, and then looking to find strengths and areas for improvement, and thinking a little bit about possible applications of the research that's being presented. We present mainly primary research articles describing hypothesis-driven research. You'll see that all three of these papers do that today. For the schedule, I'm going to stop talking, and Dr. Vacca will come on, followed by Dr. Cheng and then Dr. Jang. And then we will have question time at the end. To ask questions in this webinar format, there's a Q&A box that you can see. You have the ability to type questions in, and we'll either answer them in real time if there's something that's easy to address, or we will moderate them at the end with the speakers. You can also use the chat for general discussions or to greet each other. So I'll stop sharing my screen, and Dr. Vacca can share her screen, and the other panelists can mute themselves and turn off cameras if they like. So take it away.
All right, can everybody see my screen?
Yes, we can.
Perfect. So as Dr. Hagemann nicely introduced, I'm Francesca Vacca. I'm a third-year resident at Washington University Department of Pathology and Immunology. And today I'll be discussing machine learning for the prediction of concurrent endometrial carcinoma in patients diagnosed with endometrial intraepithelial neoplasia by the authors listed below. So essentially, a number of women will undergo endometrial biopsy for cases of abnormal uterine bleeding or postmenopausal bleeding. A number of these women will be diagnosed with EIN. So what that is endometrial intraepithelial neoplasia, and that's the same thing as atypical endometrial hyperplasia. Of these women, many will undergo hysterectomy for treatment of that EIN, and about 40% of them will have endometrial carcinoma at hysterectomy. So that's abbreviated to EC in this paper, and that is essentially endometrioid adenocarcinoma. When a hysterectomy is done for removal of endometrial carcinoma, typically lymph node sampling for staging is done. However, when a hysterectomy is performed for EIN, that lymph node staging is a little bit controversial. If cancer is found, having those lymph nodes will help stage that tumor. However, if cancer isn't found, they're not as much use, and they increase the risk of surgical complications such as bleeding, infection, or lymphedema. So the goal of this paper was to help in aiding surgical decision-making to determine which women are with EIN are most likely to have endometrial carcinoma at the time of hysterectomy. And the way they did this is they compared a number of different patient risk factors for this endometrial carcinoma using machine learning. As part of their machine learning testing, they compared many different machine learning models to see how the different models performed in trying to develop this algorithm to predict women who would go on to have endometrial carcinoma at the time of hysterectomy. So they selected all women who underwent hysterectomy for EIN at their cancer center between 2009 and 2021. And from those cases, they went through the medical records and they found 11 different risk factors for these patients. Those included age, BMI, hypertension, the American Society of Anesthesiologists score, which is a score based on someone's everyday functioning, their sort of overall health score. The CA-125, their parity, time from biopsy to surgery, sampling method, so that's whether the biopsy was a curettage, an in-office endometrial biopsy, or an in-OR hysteroscopic endometrial biopsy, radiographic endometrial thickness, the preoperative histology. Now, this didn't go into the details of the histomorphology, but it was basically, was it called EIN, simply EIN, or were there other qualifiers as part of the diagnosis, and any preoperative hormonal treatment. If values were missing, they interpolated the average values. So for numerical data, that would be the mean, and for categorical data, that would be the mode. They then tested 48 different machine learning models using the scikit-learn or sklearn Python module, and compared the performance of these models and talked in a little bit more detail about the 5 best performing models. So I have a diagram here on the side that sort of shows the process that they went through. The sklearn module basically helps them organize into a data frame. That's a way to organize the data in a way that the machine learning models can understand it more easily. The way they then developed and tested the models was a method called 5-fold cross-validation. In that way, they split up their group, as shown in the little picture, into 5 smaller groups. And they use part of that small group for training, and then they use the rest of the groups for testing of the model to see that performance. And in this paper, the mean value was used to compare between the models. A best practice is typically, before you split up your data, is to sequester a final testing data. It's a little bit unclear in the paper whether they did that or they used the mean of the testing based on the 5-fold cross-validation. So that's just a point to remember. And then of the 5 best performing models, they then discuss a little bit about the sensitivity, specificity, positive predictive value, and ROC, area under the curve, to sort of give an idea of how well these models perform. So ultimately, from their case selection, they came out with 160 cases. Of these cases, 60 patients had endometrial carcinoma at the time of hysterectomy, and 100 did not. They took the 11 risk factors and they analyzed them individually and found that no individual risk factor was predictive of endometrial carcinoma alone. And like I mentioned in the previous slide, they discussed in more detail the 5 best models. The model that performed the best with sensitivity was the XGBoost model at only about 52%. And then the one that had the best overall performance based on the area under the curve was the random forest model at 0.64. And so the best performance there would be a 1. I decided to talk about 3 of those 5 models a little bit more in detail here, just to get a better idea of what the machines are doing behind the scenes. So the decision tree model is the most straightforward of these. Essentially, it is sorting by features of the categories and trying to find the best way to sort this data into meaningful categories. So I have on the side a picture of button sorting as sort of an example. If I wanted to see the difference between a jacket button or a shirt button, I could sort based on size, based on color, based on number of attachments, and try to find a way to best sort those apart. And that's essentially what the decision tree does. It finds that best way to sort that data. Random forest and XGBoost are both based upon the decision tree method. They both aggregate a bunch of decision trees. So random forest takes those different groups of data and essentially trains up multiple different independent decision trees, and then sort of aggregates the responses of those to try and find the best overall response. The XGBoost method is a little bit more complicated. It takes these multiple different decision trees and uses a series of equations to weigh them and find the best overall response based on each different decision tree's performance. The group discussed a number of limitations with this study, namely that they had 160 cases. When we think of machine learning, typically machines do best with the more data and as much data as possible. And so 160 cases with 11 data points per case would put us around 1,700 cases. And there was about 5% missing data. So we'd be around 1,600 cases, or 1,600 data points, sorry. And then it was a single center only. So again, limited data. And also they only had available to them at the time clinical data. So we don't see a lot of discussion of the particular histomorphology, any immunohistochemical staining, or any molecular testing data. And ultimately, the conclusion that they found, since these models did not perform well, was it's not currently possible to predict concurrent endometrial carcinoma in women with a preoperative diagnosis of EIN. So the strengths of this paper, I think the main strength here is that they did a side-by-side comparison of machine learning models. It's not something that I've seen very often in the past, and I think that it's an important thing for us to do in the future, because it allows us to test these many different models and maybe decide, which ones are going to work the best for us under practical means. The way that they tested these models was using a practical application, so something that we would want to use machine learning for. They're great at sorting a bunch of different data points to try and find a decision. So this would be a great potential use for machine learning. However, there were a number of areas for improvement. So namely that small data training set that they highlighted in their own limitations. And then also something I would have liked to see a little bit more in this paper is that they don't go into too much detail about the models themselves. So it's a little unclear why the 48 models they tested were the ones that they tested. And when you do machine learning, you set up a number of different parameters. And so they didn't go into exactly why they set the parameters they did to start out the testing. I also would have hoped for a little bit more explanation as to exactly how they tested the models beyond just the 5-fold cross-validation and using a mean. And then my biggest area for improvement, I think, is the conclusion, where it's true that none of the models did perform well, but I think that the conclusion might overreach a little bit, saying that that basically because these models didn't perform, that it's not possible to find a model that does. So I have an image to sort of help us think about that on the right, where we have Da Vinci's flying machine and then the Wright brothers' original flying machine, the first plane. And both were designs made of wood and canvas, essentially. So the original plane theoretically may have been possible in Da Vinci's time, but wasn't ever actually found or designed until the 20th century. As I touched on a little bit earlier, I think that machine learning is the new trend. We see more and more papers every year, every month even, that are based on machine learning. And so to test them using a practical method like this, and to test multiple side by side, will help us decide which models are worth investing in the future and which models aren't really worth our time. And I think a question that's raised by this paper is, how much training data do we need to do a thorough assessment of these models? How good is a good assessment of these? And I think that's an important question going forward, since I think that this type of study will be important in the future. And so I think overall that this is going to have broad applicability and might pave the way for future studies of comparing these models to one another. And thank you.
Okay, wonderful. Thank you very much. So Dr. Frankie Cheng will be next, if you want to bring up your screen sharing.
So thank you for the very interesting presentation by Dr. Vacca. I am Dr. Frankie Cheng, speaking from Hong Kong. I'm a second-year surgical pathology resident working in the Pipelle Youth Eastern Hospital in Hong Kong. So I'm very fortunate to be able to join this journal club. So today the article that I'm going to present is on BRCA1/2 reversion mutation in a pan-cancer cohort. The authors are Nakamura and his colleagues. So let's first start off with some background on BRCA1/2. BRCA1 is a gene that is located in the long arm of the 17th chromosome, and BRCA2 is a gene that's located in the long arm of the 13th chromosome. So BRCA1 encodes a nuclear protein of 1,863 amino acids. It's often mutated in specific domains. BRCA2 encodes a protein of 3,418 amino acids. So so what's the significance of BRCA gene? So let's talk about the mechanism of how our cells repair double-strand DNA breaks. So when double-stranded DNA breaks occur in a cell, there are various mechanisms for our cells to repair the damage. The most accurate pathway is through the homologous recombination pathway. It is most error-free and most accurate as compared to the alternative mechanisms, namely the non-homologous end joining and the microhomology-mediated end joining pathway. So BRCA1 and 2 encode proteins that regulate the homologous recombination repair when DNA double-stranded breaks occur, using the sister chromatid as a template. So in the situation that the cells lost this function, the cell would depend on alternative error-prone pathway. For example, the NXEJ and the MMEJ pathway to repair these double-strand DNA breaks. Some of these cells might undergo cell death, while the others might experience genomic instability and hence the development of cancer. So individuals with germline pathogenic variants in BRCA1-2, so the patients with BRCA1 or 2 cancer predisposition syndrome are predisposed to a 2-hit biallelic inactivation of the genes. So there are also some therapeutic implications with regards to the BRCA1 and 2 genes. A drug has been developed called polyadipolyl ribose polymerase inhibitors. So in our normal cells, there are sometimes single-strand DNA breaks occur. Usually they are repaired by through base excision repair by the PARP enzymes. However, in the case of enzyme inhibition, the single-strand breaks will be converted to double-strand DNA breaks when the DNA replicates. And for the cells that have homologous recombination deficiency, they will undergo cell death through this mechanism of synthetic lethality. So as we can appreciate, BRCA1 or 2 mutation will predict sensitivity to PARP inhibition. And it's also quoted that the mutation also predicts sensitivity to platinum-based chemotherapy. So but the story doesn't end here, because recently researchers have found the presence of reversion mutations. So what is meant by reversion mutation? So at first we have a primary deleterious mutation. It can be either a germline or a somatic mutation. The reversion mutation refers to a secondary mutation superimposed on the primary deleterious mutation. So in the paper that we'll later discuss, the reversion mutation is defined by the author as there are 3 points here. It's defined by either having a base substitution of a nonsense mutation that converted into a missense mutation, an indel event that restored the open reading frame, or loss of the primary deleterious mutation. So how do we understand this? So in the first case, if we convert a nonsense mutation into a missense mutation, it might actually restore some of the function of the protein, because a nonsense mutation is likely to result in a large truncated protein due to the developing a premature stop codon, while a missense mutation might have a slightly less detrimental effect. And indel indel event that restored the open reading frame, that is a combination of primary deleterious mutation plus a secondary mutation producing a nucleotide change divisible by 3. This combination of change will negate the effect of frame shift. So again, possibly preventing the production of a large non-functional protein that bear no resemblance to the wild type protein. Also, if reversion mutation can also refer to loss of primary deleterious mutation due to a large intergenic deletion. So this mutation reestablish the cell's ability to perform homologous recombination because the primary deleterious mutation is reverted. And it's also it is proposed that the existence of this mutation is caused by selective pressure from a platinum-based or PARP inhibitor therapy. Because if the primary driver mutation is indeed BRCA mediated, the tumor cells that develop the reversion mutation will have a survival advantage, and they will grow into dominance. So in the same line of thought, it confirms a BRCA-dependent phenotype. So after having said the background regarding BRCA1 and 2 and and its therapeutic implication and the presence and the concept of reversion mutation, let's talk about the study design in our article. So the objective of the article is to characterize BRCA1 or 2 reversion mutation in a large pan-cancer cohort of Japanese patients. There are 3,738 patients recruited. These patients have solid tumors in the Keio University Hospital, and they underwent 324 genes, either somatic tissue or liquid-based genomic profiling tests between a period of around 3 years. So a significant proportion of the patients had canonical BRCA-associated tumors, namely breast, tubovarian, peritoneal, pancreatic, and prostate cancer. And larger proportion had non-canonical BRCA-associated tumors, like colorectal or endometrial cancers. So paraffin embedded samples or liquid samples were assessed with the Foundation-1 assay, and the pathogenicity of the BRCA1 or 2 variants were assessed with the ClinVar classification. So let's look at the prevalence of BRCA1 and 2 mutation. So in the somatic tissue cohort, around 5% of the patients with solid tumors have either BRCA1, BRCA2, or co-mutation, while in the liquid-based profiling cohort, there are 8.1% of the patients with solid tumors harboring BRCA1, BRCA2, or co-mutation. So quite a significant proportion. And it is also found that the prevalence rate of BRCA1 or 2 mutation were significantly higher in the BRCA-associated cancer than in non-BRCA-associated cancer, which is expected. So among the 208 patients with BRCA1 or 2 pathogenic mutation, there are 21 reversion mutations observed in 12 patients. 3 of them have primary BRCA1 mutation and 9 of them have primary BRCA2 mutation. And among these 21 reversion mutations, 3 were detected in BRCA1 carrier and 18 were detected in BRCA2 carrier. And it is noted that there are cases with multiple BRCA reversion mutation because the tumor cell might develop into various subclones, and different subclones might have a different reversion mutation, and they will be detected. So one case have 2 primary BRCA2 mutation, and both are seen to be reverted. And we also see that these reversion mutations tend to accumulate in specific regions of BRCA1 and 2, which is also expected because the primary mutation themselves do accumulate in specific regions. So there are 5 different cancer types observed in this patient. Most of them are canonical BRCA-associated cancer, namely breast, tuboovarian, peritoneal, pancreatic, and prostate cancer. But remarkably, there's a case of gallbladder cancer. While cancer of the biliary tract has been associated with BRCA mutation, it's not considered as a canonical BRCA-associated cancer. And almost all primary BRCA1 or 2 mutation in these patients were germline. And most show disease progression while on platinum-based or PARP inhibitor therapy, as we have discussed the concept of acquired resistance. But there's notably one patient who did not undergo either therapy. So this is just a timeline to illustrate the disease trajectory of these patients. So we can see that most of them develop recurrence or progressive disease while on the platinum-based and PARP inhibitor therapy, and they later somewhere along the disease management they are found to have a reversion mutation. So these are some of the genetic sequence of the 12 patients. So I'll pick one or two to have a look for us to have a look. For example, in the case 1, we can see that the original germline mutation results in a stop codon of TAG, and that results in that is likely to result in a largely truncated protein, while the reversion mutation reverts the effect and reverses the effect of the primary germline mutation. In the case 2, case of fallopian tubal cancer, the original germline mutation result in a frame shift effect, and the substitution in the reversion mutation reverse the effect of the frame shift. So these reversion mutation negates the effect of the deleterious effect of the germline mutation, causing the cell to regain the ability to perform homologous recombination. So these are the genetic change in the other cases. We can see that some cases have multiple reversion mutations. So a point that we also want to have a look is that is how these reversion mutations arise from. The authors have proposed one mechanism, that is the microhomology mediated end joining. So as we have discussed previously, it's one of the pathways that cells repair double-stranded breaks, but is relatively more error-prone and less accurate pathway. It involves the polymerase theta. It's a DNA damage repair pathway for end joining small sequence homologies closely related to the breakpoint. But it's not a very good mechanism for doing so. The author has observed 8 MMEJ-related deletion in 4 patients. So can be a significant mechanism in which these reversion mutations arise from. And we also see a case of gallbladder cancer with BRCA2 reversion mutation. While pathogenic variants of BRCA1 and 2 have been associated with increased risk of biliary tract cancers, it's not a canonical cancer type. And in this case, we are unclear whether BRCA is indeed a pathogenic driver. But this case responded positively to platinum-based therapy before detecting the reversion mutation. So the clinical presentation gives us a suggestion that the initial phenotype might be in fact BRCA-mediated. So lastly, also want to highlight some area for improvement of our article. Firstly, we have to be critical to evaluate our proposed theory regarding reversion mutation. We might be wondering whether the occurrence of reversion mutation in fact reflect BRCA-mediated phenotype, or maybe it's just simply a random event or pathogen mutation. As there's a case of pancreatic cancer with no history of either PARP inhibitor or platinum-based therapy. So that kind of contradicts the model that we are discussing. But notably in this case, the patient had a high mutational burden due to MLH1 methylation. So the second issue is that some of these tumors may develop mutation back to the wild type. So in that case, the tumor cells which do this we might not be able to detect the primary nor the secondary reversion mutation. So they will just exhibit the wild type allele as normal cells. So in this case, either the somatic tissue or liquid-based genomic test might not pick up this case. But I think I can imagine that this case will be the effect will be similar to having a reversion mutation as we have just described. And there's also a sensitivity issue in detecting mutation for liquid biopsy. So the last slide is about some potential real-life application for the concepts in this article. In the future, when we better characterize and profile the reversion mutation, we can develop targeted sequencing for these reversion mutations. The author also proposed blocking the other two mechanisms for repairing DNA, double-stranded DNA breaks, the NHEJ and MNJ repair, to prevent the tumor cells to accumulate this reversion mutation and hence drug resistance. So that's a potential future direction that we can consider. Lastly, monitoring the mutation status along the course of disease progression. So not only at the primary diagnosis, but also we can do the sequencing in the metastatic tumor tissue or do a liquid-based biopsy. That monitoring in such ways can be beneficial in guiding treatment, as some of these patients can acquire treatment resistance. So thank you for listening to my presentation. Thank you, Dr. Hagemann and Dr. Wolsky for arranging this journal club and recommending this great article for us to read. Thank you.
Thank you very much, Dr. Cheng. Great presentation, and really appreciate you going through that somewhat complicated decision analysis for deciding what constitutes a reversion mutation. And notice this paper doesn't address only gynecologic cancers. It's a little bit of a pan-cancer, but the biggest players there were GYN. So Dr. Jang will come in for her paper. Invite you to start your video and share your screen.
Yes, I'll do.
Great. Looks great.
Okay, great. So yeah, thank you everyone. Unfortunately, my first name doesn't start with an FR, but you can call me friend Sylvia. Excited to present this article. I'm right now in Houston, but in a week I'll be in St. Louis, Missouri for a fellowship under the tutelage of Dr. Hagemann. And so the article I'll be talking about is Endometrial Pipelle Biopsy Computer-Aided Diagnosis, a Feasibility Study by Dr. Vermorgen and group. And they are mostly based in the Netherlands, but some of their authors are from elsewhere in Europe, US, and Canada. So the basis of their study was to see how they can approach endometrial biopsies. Endometrial biopsies can be a significant portion of a gynecologic pathologist's workload, especially making diagnoses like hyperplasia and hyperplasia with atypia can be very difficult with significant variability between pathologists. Plus, there's limited tissue in the biopsy. And so their goal was to design an AI program to see if they can pre-select those atypical cases, those potentially pre-malignant endometrial biopsies, prioritize their workflow and look at those abnormal cases. Since only 10% of endometrial biopsies typically will have those pre-malignant features. What's also unique about this paper compared to other AI-designed algorithms is that they included non-straightforward cases in their learning set and test set to really reflect better the real clinical workflow. And so how they executed this was they selected 2,900 random Pipelle endometrial biopsies from their institution in the Netherlands. They recruited 15 pathologists from across the globe to assess 91 of these cases and to put them into one of these 6 categories here: non-representative, normal, non-neoplastic, hyperplasia without atypia, with atypia, and malignant. And then they also had they divided these two into a binary system of benign, consisting of non-representative to non-neoplastic, and pre-malignant to include the hyperplasia and malignant cases. Meanwhile, they had the AI program trained on the remaining 2,800 cases, and they would assess the same 91 cases that the 15 pathologists looked at. And so then they would compare how the AI classified each case to each of the 15 pathologists using a Cohen's kappa score. And they looked at how the program did for each category and also the binary benign versus pre-malignant cases. And so how they designed their AI program was based on a CLAM method, or clustering constrained attention multiple instance learning method. So they took whole slide images, and the AI would divide the tissue into little tiles, and each tile it would assess for about 2,000 quote features. And so then as it would go through the learning set, the AI would learn to associate certain features to that category diagnosis. They called this part it was paying attention or learning what to attend to. And then each tile, whichever tile had the most features that seemed to correlate to that diagnosis, diagnostic category, they could create a heat map based on this. And so red would be, oh, these tiles have the most quote unquote features that seem to correlate with the overall slide diagnosis. And so one advantage of this method is that each of the learning set slides, you only need one label for it. You don't have to have a pathologist to go in and circle every gland or every cell to label it and to teach the AI algorithm. You really just need one label per slide, which is really nice. Overall, this process takes about 8 minutes for the AI program to look at and give a diagnosis. And interestingly, this algorithm is publicly available on grandchallenge.org. So if people had cases they wanted to try to submit to the AI, they could. So for the results, they did find that their AI program did have agreement with the 15 pathologists. For the overall 6 categories, there was moderate agreement. A Cohen's kappa score closer to 1 is perfect agreement, 0 is no agreement. So they had the AI had moderate agreement with the pathologists. If you compared that to interpathologists, it was very similar. Even the ranges, it's one thing to notice that the range is wide for both the AI versus pathologist and pathologist to pathologist, but these ranges are similar to each other. So I thought that was interesting. There was even more agreement with the AI versus pathologist and between pathologists if you just separated the categories into binary and malignant, the binary benign and malignant, into substantial agreement. They also looked at, what diagnostic category pathologists agree the most on. And good thing, it's a malignant category, the most important one. So they have almost perfect agreement, which is great. But they did confirm that those diagnoses of hyperplasia and hyperplasia with atypia have bad agreement according to their kappa scores. And then also they noted that the original reports tended to use hyperplasia and hyperplasia with atypia more often than the 15 expert pathologists that looked at the cases after. So they did look at 10 cases with the most amount of disagreement or the least amount of agreement. And one case they felt was suboptimally scanned, but the other 9 cases, they really had a wide range of diagnoses, and it was associated with uncertainty. And so when the 15 pathologists looked at each case, they also denoted how certain they felt about that diagnosis. And so for one case, you can see here, blue represents uncertain, that there is definitely some uncertainty here, and that the diagnoses range from normal to atypia, hyperplasia with atypia. And this case here also has a lot of uncertainty. So kind of just confirming that the endometrial, making these diagnoses can be very difficult and there is substantial variability. So another proposal this paper talked about is that if the AI classified benign cases could bypass the pathologist, then you could significantly decrease the pathologist's workload. In order to do that, you would need the AI program would have to be 100% sensitive. So there should be no false negatives, no cases to miss that could be pre-malignant. And so they found that their AI program did reach 100% sensitivity if you compared it, if you used a reference standard of the majority vote or even just two pathologist agreement as a reference standard. You do get a higher false positive rate if you just use a two pathologist vote and a 10% false positive rate for a majority vote. And so following this, you could potentially reduce the workload of up to 72% or 50%. So overall, this paper, it was great that they included these ambiguous diagnoses and demonstrated the inter-observer variability for these diagnostic categories, and that the AI is comparable to that even with a noisy learning set and test set that the AI can perform similarly to pathologists, and it could potentially reduce workload. This paper also showed that there is disagreement, especially in that diagnostic category of hyperplasia with atypia or not atypia. They did stratify for pathologist experience level. They didn't show the granularity of this data, but they said that when they stratified for that, they didn't find any significant difference. So maybe there is more agreement the more experienced you are or based on your experience level. Clinically, they say that this is still a very limited use case because they're only looking at endometrioid malignant cases or pre-malignant cases. They're not looking at serous carcinoma, endocervical disease, infection, etc. And that in the future, they would be interested in looking at those other diagnoses. They have this algorithm on publicly available, so to get more cases from other institutions. And 8 minutes per slide. It could be faster, potentially. So they would try to parallelize for faster processing. And so for me, overall, I thought this paper was really great. I really liked that they used these kind of noisy, quote unquote, noisy test cases to better reflect real life practice. I thought that was great that they used a non-neoplastic category because there are some conditions like hormone effect that definitely don't look normal, but are definitely not neoplastic, but to an algorithm that could flag as abnormal. So I think that was a great category to include to not, to clean up their data. And that their machine learning method of CLAM for a single label per slide makes the creating a training set really easy. Rather than having to manually annotate each slide cell by cell. Some things that came up that we would like to see is maybe inclusion of biopsies by other procedures, so by dilation and curettage, by hysteroscopy, etc. Also, when pathologists look at the case, we'll also include clinical information into our decision making, and so maybe that might elevate that algorithm a little bit if it could also learn based on the endometrial stripe thickness, the age of the patient, etc., into their algorithm. A common maybe pain point is, or especially for the Pipelle biopsies, is that they're very scant, very small tissue. And so I'd like to hear from the authors how the AI program performed on those scant tissue cases, and also how the AI program would handle levels, because a lot of us get multiple levels for each biopsy case. I think inclusion of more. They mentioned that the 15 expert pathologists did not really use the atypia or the hyperplasia diagnostic categories as much, and so probably a lower end for that diagnostic category. So maybe if they included more of those types of cases specifically. Also kind of discussion on, if we're going to take this algorithm long term, what is needed for the maintenance of it, and their proposal that this use of this algorithm could potentially reduce pathologist workload. Though, I'm not sure if we're really ready to truly bypass the quote negative cases, because chronic endometriitis is still a pertinent clinical a pertinent diagnosis for a clinician. There's something actionable there. I'm not sure if we're really ready to treat endometrial biopsies how we do pap smears, that at least in the US the negative pap smears are that they bypass the pathologist, though they are reviewed by the cytotech. And so how would I envision this paper in the future? The implications of it is that this could really be a great help for workflow prioritization, really flag those atypical cases for the top so that you can have your immuno cut off or et cetera, to really work up those cases, potentially decrease your turnaround time. Although you may have to be careful, because if, at least in the US, if certain paying institutions think that we can sign out these cases faster, they might pay us less for it. So just have to be careful there. And then as a trainee, interested to see how this could be used in the education setting as well. And even for private groups that don't have residents, I could see this algorithm being kind of like a quote AI resident that pre-screens each case and highlights certain areas of concern by the heat map. So overall, I think it's a really interesting paper and algorithm. So overall, yeah, I'd like to thank everyone, and thank you, Dr. Hagemann and Dr. Wolsky, for this opportunity and their guidance.
All right, wonderful. Thank you so much for the presentation, and take away the spotlight there. So we have some applause coming in. I didn't see a great deal of, feel free to stop screen sharing. There you go. A great deal of questions in the Q&A, but I had a couple of questions, actually. I have a question for, let's see, we have a raised hand. You know what? Put your question in the Q&A box is probably the best way to do it. We would love to field your question. For Dr. Vacca, I enjoyed your presentation. I was left with a question. You told us that none of the models that the authors proposed for for prediction worked that well, and just wondering how well they really did work for predicting cancer. Like, not well, but what was the quality of the predictions that they were able to make, accuracy wise?
Sure. And actually, if I can share my screen here a little bit, this didn't show well earlier, but here's an example of a table that they did have in the paper. Basically, a straight line along this diagonal here would be just random chance. And then perfect performance would be sort of a vertical line and then a horizontal line. So the 5 best performing models are pretty close to this diagonal. So ultimately, they did not perform very well at all. And so we can see here in their ultimate area under the curve calculations that best one at 0.64 is still not great.
Yeah, I think we couldn't have a clinical test with a area under the curve of 0.64. So,
no,
okay.
no. Hopefully that answers your question.
Closely resembles a random guess, actually.
Mm-hmm.
Thank you. I have a question for Dr. Cheng about your paper. The investigators, just clarify the methods for us. The investigators were looking for reversion mutations. That means that they had a biopsy of the tumor subsequent to treatment. And I didn't understand how they came to have those biopsies. Were they done on a protocol, or they were taken because the patient had evidence of disease progression?
Thank you for your question. So to answer your question, you can refer to the PowerPoint. Let me share the screen. Okay. Can everyone see my screen?
Yeah.
Yeah, okay. So So it's a very good question. Actually, the patient have disease progression as evidenced by metastatic disease. We can see that the big arrow that is have a black and red stripe that's upside down on the top bar. It represents a metastatic tumor tissue. And so in this metastatic tumor tissue, as a evidence of disease progression, the sequencing was done on the somatic tissue. But some of them have the sequencing done on with a liquid-based profiling, and that is shown by the big red arrow that is upside down, also on the top bar. So I think it's not that these sequencing were not done according to protocol because it spans across a lot of different tumor types, and also the sequencing happens at not a very orderly manner along the disease progression. I think when the metastasis happen, or in some cases the oncologist might decide to do a foundation one, then they discover these reversion mutations.
Okay, thank you. Yeah, the reason this is important is that it shows that the results of the paper might overstate the probability of experiencing a reversion mutation after PARP inhibitor treatment. The patients who didn't progress didn't get a biopsy and didn't get sequenced.
Yes.
Great. All right. Well, I don't see anything in the Q&A box. I think we've exhausted the time available. So maybe the presenters could come back on video so we can give them a round of applause and express our appreciation to the Journal Club. We really appreciate you all being here, and to our audience, thank you for joining. Want to remind you that the membership in the International Society of Gynecological Pathologists is available to you, and in fact the fees are waived for residents and pathology trainees wherever you may be in the world. So please consider joining up. Our website is, well, our education website is ISGyP.ca, and that's probably a good launching pad for you. And we'll see you all for the next ISGyP Live event. Thank you so much for being here. Bye,
Thank you.
everyone.
Thanks, you all did excellent.